So good morning, and thank you for joining us this morning as we talk about Corp's clinic comparison reporting that we have just done. This is Megan Haggard with Corp, and I'm just going to go through some introductions and housekeeping very quickly. Just a note that I'm sure you guys already heard from AccuConference, everybody is on mute. So if you do have a question, you can use the question box, and I will show you in a couple of slides where that is on your screen, and you can feel free to submit questions throughout the webinar while we are talking, and we will answer them in the appropriate place. So just keep those questions coming if you have any at all. So today we have Mylea Christensen, who's the Executive Director here at Corp, who will be providing some background about the work that Corp has done and how we have gotten to this place. Then we have Meredith Roberts-Massey, who will be talking more about the measures and the background for the cost of care work. Doug Rupp, Corp Senior Analyst, will be talking in depth about the methodology and the reports that people have gotten. And Scott Conroy, one of our volunteer committee members, will be talking about his work with Corp on the committees that have sort of shepherded this work. And then again, we will have time for questions and answers. So this is the pane where you can enter questions throughout the webinar if you have any, and we will monitor that and then answer them at the appropriate place. We will read them out for everybody to hear because everybody will not be able to see what the questions are. So we will repeat the question and then answer it. So again, just feel free to type in questions at any point in time during the webinar. And I'm going to turn it over to Mylea.
Thanks, Megan, and good morning, everyone. We're thrilled that you out there around the state are able to join us this morning for this webinar. I would just say that this work is really the culmination of over 2.5 years of planning, and we have been very fortunate to have worked with partners throughout the state on this program really since its inception and concept back in fall of 2002. So we thought we'd just begin today with a brief overview of Quality Corp and just to set the stage and talk a little bit about context. So we are a nonprofit organization. Our mission is to improve the quality and affordability of healthcare in Oregon by leading community collaborations and producing unbiased information. On the next slide, you will be able to see we've been around for 15 years. We consider ourselves to be a neutral, independent organization. We are really rooted in the belief that all stakeholders should be at the table to solve the difficult issues of healthcare. So we frequently, in all of our work, involve health plans, purchasers, policymakers, consumers, providers, hospitals and health systems, and government partners. We have over 11 standing committees with 200 volunteers. And the project that we'll speak about today is no exception. We've had a fantastic advisory committee who has been helping us plan and implement this project over the last 1.5 years. So on the next slide, we do our work in really 3 major strategies. One, we lead community collaborations by, again, bringing those stakeholders to the table. We provide unbiased quality and utilization information, and we've done that since 2007. And we've also expanded the use of the database that we have into analytics and data that we think are important to stakeholders across the state. On the next slide, you'll be able to just see some of the national initiatives that we participate in. The Aligning Forces for Quality, Robert Wood Johnson Foundation, their largest signature effort. Quality Corp has been one of 16 organizations across the country to participate. We have the Chartered Value Exchange designation from the Agency for Healthcare Research and Quality, and we are one of 30 organizations in the Network for Regional Healthcare Improvement. And we were one of the first in the country to become a CMS qualified entity and one of the first to publicly report using Medicare fee-for-service data. Next slide is just to give you a sense of the breadth of the data that we have. We have over 3.5 million unique patients captured in our claims data. We have providers in a provider directory who are eligible to receive that information, and again, that's statewide throughout Oregon. On the next slide, just to give you a sense of what's the breadth of the coverage in terms of the population, we have over 80% of the fully insured commercial population 35% of the self-insured, 100% of Medicaid, and we're up somewhere around 92, 93% for Medicare since we've incorporated the Medicare fee-for-service data. On the next slide, you can see some of the measures that we have rolled out over the last many years. We have over 30 measures that we now produce either privately or publicly. They include measures for adults, pediatrics, utilization measures, and we are thrilled to have recently added some of the CCL metrics last year and to add the total cost of care measure this year with this rollout. On the next slide, we do a high-level report each year that comes out in the late summer, early fall. It's really targeted at those of us who are concentrating our efforts around healthcare, and it's a way that we provide a statewide snapshot on the results of our work. On the next slide, this is just a page out of that report where you can see how we're doing compared to both Oregon benchmarks and also national HEDIS benchmarks, and where there is still plenty of opportunity to improve even after many years of reporting. On the next slide, you can just see this is some of the pointing out, but this is our translation for consumers, where we actually take the same information that's produced and actually put it on a public website so that individual consumers and citizens can see how clinics are doing across Oregon. And then on the next slide is we're going to turn it over to Meredith so she can talk a little bit more about the specific total cost of care work that we've done.
Thanks, Malia. We are really, really excited to share with you the results of our first attempt to roll out clinic comparison reports. But first I'm going to give you a little bit of background and some information about the measures. So as Malia mentioned, we have gotten a great support through the Robert Wood Johnson's Aligning Forces for Quality program. We're on our fourth round of funding, and we decided to focus this fourth round of funding on both cost initiatives and payment reform. So for the past 2 years, we've really been focusing on getting this information out. In addition, we are a participant in the study through the Network for Regional Healthcare Improvement, which is also funded by the Robert Wood Johnson Foundation. So Oregon is actually one of 5 regions participating in the study that looks at standardizing measurement to provide trusted information and to enable comparisons across regions. The other 4 regions involved are Minnesota, Maine, Colorado, and the St. Louis region. So it's really across the country. Through this work, we've been working with physician partners to help them understand really what is underneath the cost and resource use measures that we'll be talking about today, and identifying strategies that they could possibly use to reduce costs and reduce variation. One of the ways we did this was through a National Physician Leadership Seminar at Stanford University last summer, where we brought 4 Oregon physicians for a day-and-a-half workshop to really understand these measures and how they can be used. One of the goals of the project was to develop clinical level reports for primary care practices, and that's exactly what we've done over the past month. We've released about 150 reports to clinics across the state. So the cost of care measures, the important thing to remember is that we are using claims data to develop a population level measure that looks at per capita commercial costs for a clinic's panel of patients. So this includes all care delivered to the attributed patients. So it includes professional, outpatient, inpatient, and pharmacy costs. And it combines payments made by the insurer and the patient for that care. These measures are risk adjusted, and we are using the ACG risk adjuster out of Johns Hopkins. So risk adjustment is really just a method of estimating a population's illness burden. It helps level the playing field between 2 populations by accounting for some of the variation that's inherent in those 2 populations. The ACG risk adjuster adjusts based on age, gender, and illness burden of that panel. We are using this as a part of the Health Partners methodology. And for those who don't know, Health Partners is an integrated system out of Minnesota. They've been using these measures for about 10 years, And over those 10 years, they've been adopted more and more nationally. Currently, there's over 90 licenses in 29 states, which really means it's spreading across the country. So we're not alone here. One of the reasons that the project chose to use these measures was they were endorsed by the National Quality Forum back in January 2012. And as you probably know, the National Quality Forum has a pretty rigorous review process. After we reviewed their review process, we determined that the measures are reliable and valid, and we agreed to start using them. One of the things that's important to realize about these measures is this is the first time the NQF has endorsed a full population total cost of care measurement approach. So we feel like that adds to the credibility of the measures. Here we show you how the measures fit in together. So Health Partners has actually endorsed two measures, the Total Cost Index and the Resource Use Index. So the Total Cost Index is the overall cost effectiveness of managing a panel of patients. It includes all medical and prescription costs, and it accounts for both price and utilization. So it's all attributed patients, all costs for 1 year. The resource use, on the other hand, the resource use index is the utilization component of the total cost index. It measures the frequency and intensity of services used, and it uses standardized pricing to isolate the utilization. So these measures are really meant to highlight cost savings opportunities and potential overuse or inefficiency in delivery of services. By simple math, you can divide the price index by removing the resource use from the total cost index component. And what the price reflects is really the actual price of the services provided and takes into account contractual variations. So with that, I'm going to hand it over to Doug, who's going to dive deeper into the methodology we use.
Thank you, Meredith. As Meredith mentioned, in a couple minutes we will review the clinic level report package that shows quality, cost, and utilization together. But before we do that, we would like to concentrate on exactly how to calculate the two cost measures, since they're the new part. As Meredith mentioned, we're using the two Health Partners total cost of care measures to compare clinics to an average of all clinics in Oregon. And the average that we're calculating is the average of the patients attributed to clinics that are receiving these reports. The first measure, the total cost index, is a measure that compares the cost of all services provided to all patients at all clinics on average to the state average as a whole. So this is just the overall cost. So first we need to calculate the total PMPM. And this is the total medical costs for the year, all costs paid by the patient and the insurance company. And those are divided by the number of member months, or the number of months that the total members of the patients attributed to the clinic were insured during the same year. And the calculation is also made with pharmacy costs separately, because the pharmacy membership can differ from the medical membership. So this gives us the total PMPM, or average per member per month cost for the clinic. In the clinic comparison reports, we call this the raw PMPM, because it's the PMPM cost before adjusting for differences among the clinic's patient population. So before adjusting for the illness burden, age, and gender, before we risk adjust. The total PMPM is then divided by the Johns Hopkins ACG risk adjuster to calculate the risk-adjusted PMPM. And this PMPM can be higher or lower based on those characteristics at the clinic, the patient's diagnoses, age, and gender. And so this gives us next we can calculate the TCI, or the total cost index. And that is calculated simply by dividing the risk-adjusted PMPM for the clinic by the risk-adjusted PMPM average. So the risk-adjusted PMPM for the Oregon average, which is the average of all clinics. Clinic scores for TCI are then compared to an average of 1.0, and clinics with a score above 1 have higher total costs than the average clinic. Conversely, clinics with a lower score have lower costs. The other component of, the second measure that we're looking at is the resource use index. And the resource use index, instead of using the costs paid by the patient and insurance company, this measure standardizes the costs for each service. This way, if two different patients receive exactly the same services during the year, they would have the exactly the same resource use weight. It doesn't matter how much the insurance company and the patient paid for the services. The measure would then is an indication of the intensity and volume of services the patient receives, as Meredith mentions, irrespective of the price paid for those services. It can indicate if more services than necessary are being provided to care for a panel of patients. So these standard weights are then used to calculate the resource use in these standard weights that are used to calculate the resource use index are called the total cost relative resource use values, TCRRVs. The resource use index has a very similar calculation to the TCI, but it uses these total cost relative resource use values, TCRRVs, instead of the actual costs. So that's the two measures in a nutshell and how we calculate them. Now we'd like to go on in through, well, it looks like we got a question that's come in. So let me take a look at that. When you mention patient cost, do you calculate out-of-pocket expected costs for copays, pharmacy costs out of pocket? And we do. So the costs that we're looking at here are all of the costs, the deductible and co-insurance that the patient pays, as well as the costs that the health plan pays. So it's the actual checks written for the care given to a patient during the year. So now we'd like to move on to the actual report package. So as of today, we've mailed out clinic reports to 69 medical groups around the state, and we've mailed a total of 123 adult reports and 44 pediatric reports. These reports have gone out in 3 different waves over the last month to the medical group, to the attention of the administrator of the medical group that we have designated for our online provider portal. And I see some of you are logged in on the webinar today. The report package contains a 2-page cover letter and then a 2-page definition and glossary sheet, followed by the 8-page report, and finally a 6-page FAQ. So it's a fairly big package. I would like to go through and focus primarily on the 8-page report where we dig into this cost and also quality and utilization. So the first page of the report is a demographics and cost overview. It shows a demographics, cost, and overview. It tells gender, age of the patients attributed to the clinic, and some of the higher level diagnoses that are grouped by CCHG, or these are clinical cost healthcare groupings that have been developed by our data vendor, Milliman. So the patients that appear here are patients that we have attributed in our database to a doctor at the clinic. So these are not all of the patients that you have. We're using cost information for a large number of providers. As Malia mentioned, we have a large number of providers that supply us data for our quality measures. We have a subset of those that we're able to use cost with right now. So this is not your entire clinic panel. And again, these are patients that are either in the pediatric population or the adult population. There are separate reports for those 2 groups. And the ages are limited from 1 to 64. So also on the initial page is an overview of costs broken out by professional, outpatient, inpatient, pharmacy, and then a total line for the total cost on average. And finally, there's a scatter plot that shows where this clinic appears in relation to the other clinics receiving these reports on the total, on the resource use index and on the price index. So the two components of the total cost are on the two different axes. And we'll talk about that in a little more detail in just a minute. The rest of the report breaks out those different areas, professional, outpatient, inpatient, and pharmacy, in more detail, and discusses both costs as well as quality and the utilization. For the quality measures, we have included the same quality measures that Mylea showed earlier in the presentation, and we've included those on the pages that where they best fit as far as inpatient, outpatient, pharmacy, or professional. The utilization data that we're using is for the same age population as is on the report. So if you're receiving a pediatric report and you have both pediatric and adults in your clinic, the pediatric report shows utilization only for the pediatric population. There are two additional drill downs in the report. There's a page that shows imaging and emergency room cost and utilization, and a page that shows chronic conditions cost and quality measurement. So the clinical characteristics, or the clinical comparison reports, as I mentioned, are separate for adult and pediatric. And we have a requirement of 600 patients. This is the number of patients that health partners use to get the NQF endorsement, and so we've stuck with that. There is a possibility we'll go down to a few hundred less patients because as we look at our data, we just want to make sure that the data is reliable if we decrease those numbers. In other regions, other people who have been using the health partners measures have reduced the number of attributed patients. The other component that Meredith mentioned is that the costs are capped at $100,000 per year per patient. And what this does is it sort of levels the playing field for clinics that have unexpectedly high costs. The risk adjuster does a pretty good job of accounting for the differences in illness burden, but this helps to make sure that no clinic is penalized for patients that have very high medical costs. Overall, we're able to calculate these total cost measures for about 35% of the commercial population in Oregon. As I mentioned, we have a larger portion that we can run quality measures on. A subset of the data suppliers that we work with, a subset of the health insurance plans that we work with, we're able to use cost data for at this time. That's sort of the overview of the reports. There's a lot there, and we've got more information on our website at qcorp.org, our work, cost of care, or you can email us at costofcare@qcorp.org, and I think all of that is information is with the report also. So please feel free to contact us. This is very new information for a lot of people, and we want to make sure that what we're sharing is clear to everyone and makes sense. Additionally, this is new to us too. So every time we talk to a clinic administrator or a doctor, as we've done a lot of over the last year and a half, we learn more about healthcare in Oregon as a whole, about clinics, and about how these measures actually work. So we appreciate the interaction. So I've broken out a few shots that come directly from a sample of the reports. The chart in the upper left on this page shows the high-level cost information I mentioned with the last slide. So down the left, there's professional, outpatient facility, inpatient facility, pharmacy, and overall. And the first column shows the raw PMPM. As I mentioned, this is the per member per month average cost for the patients attributed to the clinic with those caveats that we mentioned. If this is an adult report, it's patients aged 18 to 64. The costs are capped at $100,000. And that's how we come up with the raw per member per month. In this case, it's $417.03 for this clinic. Next is the adjusted PMPM. And if you recall, the way this is calculated is by dividing the raw PMPM by that risk score. So just to the right of the chart we're looking at is this clinic's risk score. It's 1.11. Because it's above 1.0, this clinic has a higher illness burden as calculated by the Johns Hopkins ACGs, has a higher illness burden than the state as a whole. So we would expect this clinic to have higher healthcare costs than the state as a whole. Back to the chart, on the adjusted PMPM, we're dividing the raw PMPM by that risk score to lower their costs below what they're actually appearing as. This sort of compensates for the fact that they have sicker patients than the state as a whole. The next column is the Oregon average PMPM. And as we mentioned, this is the average for the entire state. In this case, $424.06. The next two columns are the health partners measures. First is the TCI, the total cost index. And the total cost index is calculated by simply dividing the clinic's adjusted PMPM, 376.26, by the Oregon average, 424.06. And that gives us a TCI of 89. A TCI below 1.0 means that the total costs for this clinic are lower than the state as a whole. In this case, 11% lower, because it's just 89% of the total cost. So the next column is the resource use index. It's a component of that total cost. This is calculated using the standard costs. There isn't much other detail on here that shows how those standard costs are calculated. But the total resource use index in this case is 0.85. That means that the resources and the intensity of services that they're using to care for their patients is about 15% less than what we would expect if they were the average in the state. And as Meredith mentioned, we can then derive the price index from those two other indices. In this case, for the overall costs, this clinic is at 1.05. That's higher than the average of 1.0. This clinic is about 5% higher than the average clinic in the state. So the prices that are being paid to care for these patients are higher than the average. So as I mentioned, the lines above, professional, outpatient, inpatient, and pharmacy, break out these costs into those different buckets. And I just wanted to call out in blue anywhere on your report where the costs, either any of these, the TCI, the RUI, or the price index are higher than 1.10 or higher than 10% over the average, they're highlighted in blue just to call out the places that you might want to specifically concentrate. In this case, professional charges are 1.11 or about 11% higher than the benchmark, and inpatient facility is about 13% higher. The chart below is a bigger version of the scatter plot that I mentioned a couple slides ago. And in this case, you can look directly up to the overall RUI and price index of 0.85 and 1.05 and see them on the chart here. In this case, the clinic is in the upper left quadrant, and that indicates that the prices are higher and the resource use is lower than the average clinic in the state. So on the next slide, we've got more of a drill down, and I just wanted to give an example of how you can go from that initial slide to the more detailed slides as we go in. This gives, in the upper left, the same chart that we looked at, the same overview chart that we looked at that's on the first page of the report. And then it breaks out, it jumps to the inpatient page. So on the upper right are costs that are pulled out of that inpatient facility line into more detail, showing the surgical, medical, maternity, and mental health costs for inpatient, as well as non-acute care, which is skilled nursing facilities. And again, we've got scatter plots for each of these. So this is the inpatient scatter plot, which shows a similar story to what, although a little more extreme, story to what we showed on the overall costs. The clinic on resource use is below the average, and the price index is above. We've also been able to look at the clinics as a whole around the state, and we're beginning to think about how we're going to report cost in the statewide report this year. The initial findings are shown on this TCI slide. So this is the total cost index, and each of those vertical lines represents a clinic in Oregon. So this kind of lines up the different clinics around the state and how they are in relation to each other. Again, the average is 1.0, and on the right are clinics that are higher in total cost. On the left are clinics that are lower. And for anyone who's interested, the standard deviation of 0.12 is also shown on this chart. The next slide shows the relation that we're seeing between the cost indices and our quality measures. This, for example, is the total cost index versus the breast cancer screening rate. And so across the bottom are all the clinics it shows the low of 0.6 to 1.4 for the cost, and then up the left side is the score on the breast cancer screening measure. And the scatter plot shows that some clinics have low cost and are doing well on breast cancer screening. Some are not doing so well on breast cancer screening. Some have higher costs and are doing well, and others are not. And what this scatter plot indicates, because the dots are all over the place, is that there doesn't seem to be much correlation between the costs as indicated by the total cost index and quality as indicated by our breast cancer screening rates. So more to come on views around on looking at the clinics in different ways across the state. Next, I'd like to introduce Scott Conroy. Scott graciously serves on two of Q-Corp's committees, the Measurement and Reporting Committee, where he advises Q-Corp staff on measure selection and other data-related issues, and our Cost of Care Steering Committee, which has been key in developing these clinical comparison reports, as well as advising Q-Corp on other cost of care work. So Scott would like to share some of his experiences. Scott?
Thank you. I wanted to go back first and say that this project started with the Q-Corp board and the Measurement and Reporting Committee weighing in also, remembering the idea of a triple aim and adding that third leg, i.e. cost per member per month. And the charter that I was a part of affirming, if you will, included a committee of stakeholders and a goal of getting information to medical groups that they or you could use to inform themselves about how their practice performed, or their practices, if you have multiple sites, compared to other practices across multiple commercial payers, and hopefully in the future, the state payers. The whole intent of this is at some point to make this information actionable, but more importantly at this point, it is to get that begin to get that third leg of information about the AAA and cost per member per month into the hands of primary medical groups and medical groups in general, so that you can begin to think about how could we use this to affect what we do. It has been interesting because the Q-Corp meetings in general are this way, but the breadth and depth of discussion was, and the vigor with which the multiple stakeholders engaged with each other was incredible, and I think incredibly informative and useful. The stakeholders did include, for those who may or may not know, medical groups, clinicians, researchers, health plans, purchasers, and it was consumer advocates. It was incredible to hear the different perspectives of each of those stakeholders and the depth of feeling that they had about the importance of this information. I'm going to stop there, but I also just want to say big-time kudos to the Q-Corp staff for keeping and maintaining their principle of validity, reliability, accuracy, fairness in the process, and they've done a wonderful job of that.
Thanks so much, Scott. So this is Meredith again, and I have to say that we owe a huge thanks to Scott and his colleagues that serve on these committees. We really could not have done it without them. So this slide just shows a snapshot of what we've been up to over the past year or so. As Mylea mentioned, this has been a 2+ year process, and we've really focused our activities in the past year about getting the message out that these reports are coming, and getting guidance from our stakeholder groups about the best way to present this information and communications around these reports. So this slide gives you a sense of who we've been working with and who has put effort into this process. We've really reached out to everyone we could think of, including some focus interviews with clinics around the state. So we actually got an independent research group, the American Institutes of Research, to come in and do some neutral facilitation focus interviews with clinics with their actual data. And this kind of gave us a sense of the way clinics might view this information and ways we can enhance the clarity of the information in our communications. I just want to mention that later this month, we actually do have a rollout event in Portland, so on May 20th. For those of you who want to come meet the Q-Corp team, we are going to host a rather informal event where we'll be sharing a lot of the same information you heard today, but also it'll give you an opportunity to ask focused questions about your own reports. So just to give you a sense of the next steps, as we mentioned, we've been working with this Network for Regional Healthcare Improvement project for 18 months. We're happy to say that a Phase 2 grant has been approved by the Robert Wood Johnson Foundation, so that actually started on May 1st and goes through at the end of October of next year. Some of the things that we're hoping to do in the next 18 months is really study the variation a little bit more, variation between years of data for each clinic. We want to improve the clarity of the reports, the usefulness of the reports, and we also want to produce information that will be useful to multiple audiences. So we're looking to audiences beyond primary care groups who might find this information useful, and we're doing our best to collaborate with those groups on what would help them in their endeavors to reach the AAA. We are really excited about the potential to measure Medicare and Medicaid cost and resource use. This is kind of a new area. People around the country are trying to figure out a way to measure these costs and resource use for the non-commercial population, and we're excited for the potential to be a part of that process. And with that, I am going to turn it over to Megan, who's going to remind you how to ask questions.
So again, if anybody has questions, please type them into the questions box, and we will answer them. I do believe we have a few already that Doug is reviewing, and we'll answer, correct?
Yes. So a question that came in, only attributed patients are included in the reports, and that is correct. We, for the clinic, obviously it's only the patients that are attributed to that clinic, and for calculating the benchmark, we are using the patients attributed to clinics that we're reporting on. Next question, did I hear that charges are indexed from the clinic's own claims data, and then these charges are adjusted based on standard costs so that the expense data is converted to actual cost estimates before the indices are calculated? So for the two indices, it's done a little differently. The total cost index uses the actual costs for the services that were provided to the patient. So these are the sum of a total of all of the costs that the health plan and the patient paid. That's how the total cost index is calculated. The resource use index does use standardized costs. So instead of using, so if an MRI is done at two different locations, no matter what the insurance company and the patient paid, the same cost would be used for both of those locations. And the idea here is that it takes out the price component and weights the different services that the patients are receiving equally so that we can see how many services one patient and one patient population received compared to a different patient population. Are the TCI in the breast cancer screening slide total costs or TCI for breast cancer screening only? And these are the total costs. So we're looking at the same, on that chart, the total cost index is for all of the costs attributed to the panel. Are there any other questions out there? I wanted to go into a little more detail on the attribution. I know a lot of you are familiar with how QCOR attributes patients. We are using for the total cost index very similar attribution methodology that we use for our quality measures. So the patient has to have a visit with a PCP at the clinic within a 24-month period. And any time the patient has seen more than one provider, the latest visit is taken, the most recent visit is taken. And then, so I just want to make sure that folks are clear on how that works. There's more information, again, on our website of how that works, or if you have specific questions, please let us know. We had another question come in. Are there any distinguishing characteristics of clinics that help sort out high and low-cost clinics? This is an excellent question, and we are just beginning to dig into exactly what it is that causes certain clinics to be higher cost than others. Again, there are two components to that. It's whether the resource use, whether the intensity of services being provided is high, or whether the cost is high. And we are seeing variations on those two things. We want to look in depth and would like to report on variations between regional, by urban, suburban, and frontier communities, by the sizes of the clinics, whether they're PCPC-H clinic, certified clinics. So there are lots of different ways that we want to look and make sure that we, and to see what affects clinics. Other folks have done studies on this, and there are certain characteristics that they're finding. So we're also looking at validating those kinds of things. Oftentimes, it's clinics that have extended hours and are available for the patients at 24 hours a day. The patient can call the clinic instead of going into an emergency room where they're experiencing higher costs. So more to come. We're very interested in looking at what else there.
So, and this is Leah. I would just add one thing. I mean, it's been fascinating over the last couple of weeks as clinics have actually seen their results and started to kind of dig into the results that Doug's talking about. And I think that the really important piece that Doug was alluding to is it's really not like there's a right answer or a wrong answer. It's that you really have to take the context of your clinic and your practice. For example, it could be that you have much higher utilization in a certain category that's actually being done by design because you are actually trying to improve care, and there might be a very appropriate reason for that. And so I think we've had many good examples of that. So one of the things that we're trying to say is that it's really, really important for clinics to really look at this information, see kind of where does it lead them in terms of the next level of information, and that it's not good or bad per se in any category. It's really looking at the total results. So,
yeah, thank you. Another question: is there an adjustment for hospital costs, which is outside the control of clinics? So is there an adjustment so we can compare total costs that are across the state? And the way the total cost measures work, these are a population-based measure, and we are looking at all of the costs for a patient. This is one way of looking at costs, and Q-Corp decided to go down this path because we do see validity in looking at the costs in the state in this way. But we recognize that not all those costs are easily controllable by clinics. We are hoping that our findings do point out variations, and variations in hospital costs. We know that different regions around the country, those costs can look very different on both resource use and total costs. What are the next steps for clinics that want to address a high cost index? What is the first step? Scott, what have you all done? And I'll go ahead and answer this from the perspective of what we've seen, because we have talked with a number of clinics. We've talked with clinics that have higher total cost indices, and it really depends on what parts of the report the clinics are seeing higher costs in. You know, if a particular clinic has a particular kind of patient, then we would expect that has a higher illness burden, is known for treating a particular kind of patient, then we would expect to see higher utilization possibly in those areas. And so clinics are not surprised to see higher resource use index in certain cases. We were talking to the system administrator last night who was pleased to see his behavioral health cost utilization higher than the state average, because they have been concentrating on making sure that their patients get those services that they feel they're not getting enough of. So it depends very much on the clinic and what they're seeing. But if a clinic, and we've had clinics that have dug into their own systems to see and validate certain pharmacy numbers that they've seen that are high, or possibly specialist charges, utilization that they're seeing is high. So it really depends on the clinic and what the numbers actually show. We're hoping during this next phase of the grant that there may be possible ways that we can pull out things. But at this point, we're looking to the clinics to see what they can find in these numbers.
And I'll just add that we would really like to continue discussing findings with clinics. So if you have a specific score that confuses you or you want to think more about, we're happy to have a conversation with you and kind of put our heads together about what that might mean.
This is Scott, and I think that the number one thing that I would think is important is first understand the information, and it's taken most of us who have been involved in the committee well over a year to really get a sense of what these numbers say and what they don't say. So that's the first. I mean, ask questions. The second is begin to look at this as a affirmation or not of what you already might think is going on. Because, again, the more you begin to look at this information and understand it, at least for me, the more aha experiences we had and or the more, kind of thought that might be the case experience, which then informs as you move forward, how do you want to begin to either use your internal data or more information that QCOR may be able to develop that allows you to begin to address issues moving forward. I think it's important to remember that this is a longitudinal data and it begins with the year 2013. So anything that you've done since January of 2014 and even before that is not reflected in this information. And so that is, but it's not intended to be current. It's intended to be accurate, reflective of what happened. So I think that's the other thing that you use it to begin to move forward, either getting more information and or begin to use it with your quality efforts and initiatives and discussions with other stakeholders that you're working with. Say, what does this mean? How would you fit into this? Be it specialists, hospitals, payers, whatever.
Great, thanks, Scott. So another question, since the risk score adjusts for differences in age, why do you exclude numbers greater than 64 from the analysis? So the risk adjusters do a good job of estimating the illness burden of a population, but they don't do a perfect job. And as age increases, those costs, the cost of care for people in the senior population are very different from what they are in the younger adult population. So health partners made the decision to exclude those folks in those upper ages just to make the populations between clinics more comparable.
And this is Mylea, that the thing I would add, which Meredith mentioned too, is that in this work in this next phase, obviously if the Medicare, if part of the development is to figure out a way to add the Medicare piece and the Medicaid piece, there would be some revisiting of that issue. But again, to stick with the measure that had been recognized and use it in the same way and the same methodology, that's why the decision was made to stick with the measure as intended.
So I think just thank you all for joining us. I want to say I'll turn it back to Megan, but I just want to thank you all, and please, we are very available. This is our first round of data, and we're excited to get it out. We're looking, as Meredith said, we're looking at being able to report on the 2014 data and really see the variations between year over year and those effects. So we've got a lot more to come on all this.
So this is Megan. Well, thank you all for attending today. We did record this webinar, so we will be posting it on our website on the cost of care page that we mentioned earlier. You can feel free to direct your colleagues to it if they were unable to attend. Also, again, feel free to let us know if you have any questions. We are happy to talk with people and walk through reports if you want to go through more detail or have any comments or feedback or suggestion. The email is on your screen now, as well as the QCOR website. So thank you again for your time, and hope everybody has a great day.